Welcome to Knowledge on the Go, where we explore the leading practices that have emerged in Vizient's PI programs. Transitions of care remain one of the most vulnerable points for patient safety. And while accurate medication histories are vital for safe treatment, rural and resource-limited settings often face staffing challenges that make this process difficult. Today we are joined by Jenny Slavens, Inpatient Clinical Manager at IU Health Arnett, who leads a regional medication history program for a 200-bed hospital and several critical access facilities. I'm Jim Lichauer, Senior Performance Improvement Director at Vizient, and today's host. Jenny, welcome to the podcast.
Thank you, Jim. I appreciate this opportunity to talk about my team and our services.
So Jenny, why don't you walk us through the structure of your medication history team, staffing, coverage, the hospitals you serve, your hospital itself, and talk about how you've structured your program.
My team currently is made up of 10 FTEs of pharmacy technicians. Their home base is IU Health Arnett, which is located in Lafayette, Indiana. We are a 200-bed rural community hospital. My team there serves the ED, all the inpatients who are needing medication, home medication lists recorded. And something I think is unique about our team is we also do a lot of surgical medication histories. I know that's not something many med history teams are doing in current state, at least within IU Health Arnett. So we are actually doing med histories for surgical patients who are being cared for at the hospital as well as at our ambulatory surgery center, which is on the campus of IU Health Arnett, but is not physically attached. On top of the work we do at Arnett, we also serve 3 critical access hospitals. So we serve IU Health White Memorial, which is in Monticello, Indiana, IU Health Frankfurt, which is in Frankfurt, and then most recently we've acquired IU Health Tipton. So we started doing medication histories for those patients back in July. The structure, we are 24/7, 365 days a year. So we do see patients all throughout the day shift, night shift, all of it.
So what about the coverage of the critical access hospitals? What service do you provide, and during which hours do they cover their own medication histories?
It is a little bit different. It's not the same for each facility. White and Frankfurt, my team covers them 24/7. We are doing those medication histories for those patients locally at Arnett. IU Health Tipton, they have a team of technicians there on site that are doing their medications during the daytime hours. So they are completing those 8 a.m. to 3 p.m. And then my team takes over at 3 p.m. and then services those patients until 8 a.m. when the team comes back in the next day.
Your program is currently a pharmacy technician-driven model. It didn't start out that way. Can you talk about that evolution from a nursing-led model to a pharmacy-driven model?
Back in 2008, when IU Health Arnett opened, it was a nursing-led process to complete the home med list documentation, med history. And it was a team of 3 nurses, and they were part of what we called the ADT team, which was admission discharge team. They kind of wore multiple different hats, but one of their hats they wore was talking with patients and recording their home meds. On top of that, they also did like post-discharge follow-up phone calls. While they wore many hats, they did a good job from what I saw and witnessed. They did call pharmacies. They weren't just verifying with the patient. They asked the more in-depth questions. The team of nurses didn't actually report to pharmacy at the time when the hospital opened. They reported to respiratory therapy, which was kind of funny. Over time, obviously, it was recognized. Are nurses the best people to be doing this work? Should it be pharmacy? Should pharmacy lead this team rather than respiratory therapies? In 2013, they came under the leadership of pharmacy. And then gradually, as nurses left by attrition, pharmacy backfilled those positions with pharmacy technicians. From 2008, we obviously look very different. We are now a team of 10 technicians serving multiple different facilities.
You're doing phone-based medication histories. Can you discuss why you're using phone-based and not some newer technology, iPad, web-based technology?
When our team started doing med histories for Frankfurt and White and now most newly Tipton, we were utilizing telehealth through an iPad. The iPad was physically attached to a cart that had to be wheeled into the patient rooms by the nursing staff, logged into, and then the program pulled up and set up. So it was honestly quite the process to get all of that done. And the time it took to take a nurse out of bedside care became somewhat of a frustration for the nursing team. In 2020, when COVID hit, rolling extra carts in and out of rooms and making sure things were correctly cleaned was not something we felt like was the safest at that time. So we were actually asked to stop doing that and then go to just doing phone calls. In current state, for 5 years or more, we've been doing just phone call-based medication history. So ideally, my team is trying to call the room phone of the patients, but we also call cell phones as well.
What's critical in this is communication. Knowing the patient is ready and available for a medication history so it can be completed in time for admission, and also communicating back to the provider when the medication history is complete. Can you talk about that bidirectional communication and how it works at your facility?
Our electronic medical record, how it works for my team, when the admission order is placed, there is an automatic task that comes to my team to go complete the medication history. So they are alerted automatically into what we call our task list. And the nice thing is I could see any task within IU Health as long as I am just viewing that facility. So from IU Health Arnett, my team can see all of the tasks at Arnett, Frankfurt White, and now Tipton. When my team completes their medication history and checks off that task, it auto-populates what we call the little green check on the medication list, which is the trigger to the physician. The home meds have been recorded, they're accurate. It's time for you to do your next part of the reconciliation process. There is a trigger to the physicians, but there's nothing that dings them in the moment. The physicians would have to physically be in the patient's chart, click on the med list, and then see that little green check to know that it's complete. My team, if they are aware that a physician is waiting on a medication history, we can call the physicians to let them know that something is complete. We also utilize Diagnotes, or also known as Backline, as a secure texting platform. So we can communicate through that when something is completed or needs updated, any of that quick type of communication that might be necessary through this process.
Talking about timing again and focusing on that, what's your goal as far as getting the medication history done? What's your window of opportunity? Many of our organizations are looking at 24 hours, still struggling to meet that. The ideal goal is hospitalist or acute care provider can have that information to complete admission orders. So what's your goal at IU Health?
Our goal at IU Health was set several years ago by a collaborative team of pharmacists and nurses and providers identify what we felt the ideal time frame was. Our standard at IU Health is to get 80% of medication histories completed within 4 hours of that admission order going in. The 4 hours was arbitrary, but we felt like that was early enough still to provide physicians time to get it reconciled within that 24-hour goal that is set by Joint Commission. We do at Arnett, I don't know if any other facilities do this, I should say not just at Arnett, but in our region, we do for our emergency department patients have an order that will print in our office, a little sheet that says, this patient, a bed has been requested. So usually the bed will be requested before the admit order will go in. We call it time zero. So we ideally for all of our ED patients would prefer when the hospitalists come to assess the patient, that the med list is already there so they can make kind of their full assessment as they're admitting the patient.
You mentioned 80% of the time getting it done with 4 hours. How are you doing both historically and then, new to your region? You said Tipton. How are you doing there since that's a newer facility that you've added on, increasing workload? Has it impacted your success at the other sites also?
We have really great metrics, and we would not be here if we didn't have the support of executive leaders recognizing this is an important role on the admission process and to kind of help with those transitions of care. I have a great team who is very efficient and hardworking and recognizes that this is a very important task. But yes, all of those things together have lent us to having enough FTEs to have really great metrics. Arnett, throughout this year, we have scored anywhere from 82 to 86% of our patients are getting medication histories done within that 4 hours. The same goes for Frankfurt White. So we are typically in the top 3 to 4 facilities within the 16 facilities within IU Health. When we acquired Tipton, they are not a 24/7 facility. They're a critical access hospital, so they only have 8 to 4, I think, are their hours. Patients who come in after night, their medication histories were sitting there. So of course, it would be expected that they would not meet that 4-hour mark consistently. So of the 16 facilities, they were more consistently towards the bottom until we took them over. An example, in June, the month before we acquired them, they had 10% of their medication histories completed within that 4 hours. We started doing their med histories on July 1st. And in July, they were up to 76% of med histories completed in 4 hours. And then in August, they were at 72%. So I'm hopeful, we've kind of hit some snags, merging our two teams together and communicating and just figuring that out. Tipton was the outlier with their techs on site doing the medication history. So they are pulled in multiple different directions versus the Arnett team that is servicing White and Frankfurt. It's just my team only doing med history. So they are focused in that task list all the time. coming from 10% up to in the 70s is extraordinary for 2 months of doing this service. So I'm hoping over time, we have worked on some communication to better alert the Tipton team when they have a medication history that's sitting in there, just because their technicians might not be sitting at a computer looking to know something has populated. So we've kind of come up with some secure texting platforms to alert them a little bit faster to help some of that day shift time when they might be pulled in different directions.
From a staffing perspective, balancing workload and prioritizing workload, you're covering surgical patients, inpatients, ED, knowing ED patients get a priority, but then in critical access hospitals, it's unpredictable how many you're going to get on a daily basis. So how do you both balance and prioritize that workload and make sure your staff is busy and also available when an ED patient gets admitted?
We currently have 2 technicians that are working on inpatient admissions from 7 to 4:30. So we have 2 people kind of scheduled within that time frame working on inpatients. Outside of that, we have 3 FTEs that are doing surgery. One of the kind of the unique things in balancing this is surgery is so fast. The patients come in, they're very efficient, well-oiled machines kind of working through all of their pre-op checklists that they have to do. We also have to be pretty fast at doing that. So I have found having more FTEs to do surgery is necessary just to keep up with that and make sure the patients are getting talked to before they're pulled back to go to the OR. We are lucky in the sense that because all of my team members go from inpatient to surgery to the outpatient surgery center, they kind of know who is busy. They talk. Like today, for example, our outpatient surgery, our tech in the surgery center out there had 35 surgeries she was seeing in a 10-hour shift, which is very fast churn. So we knew she needed some extra support to kind of format things for the next day. Largely to stay on top of it and make sure the workload is balanced just really takes a team that melds well together to talk, to update, hey, I need help here, and not being afraid to ask for that help.
Overall, good results, outstanding program. When you brought on Tipton, what about staff satisfaction, physician, nurses, any feedback, thought of you taking workload from them? Is that a positive, negative? The physicians, the timing's not right, could it impact their flow? Did you get any feedback from the staff, and how is that going from their standpoint?
We've gotten really great feedback. Working through the nurses overnight, having someone call their patient versus having someone in person while they wouldn't normally have anyone in person after 3 or 4 p.m. I think that was just kind of a learning curve. And some nurses have advocated, like, my patient is having trouble hearing you through the phone. Working through the newness of doing that through the phone has been one piece of feedback that I've had to share with my team, just of, this is new to them. If they're acting frustrated with this process, let's try to work through how we can better help them so we can get the answers we need from the patients to get their med list recorded. Part of our process of doing the med history, we ask the patients where they want any prescriptions sent at discharge. So whether that's the on-site retail pharmacy or their retail pharmacy of choice in the outpatient setting, we update that so it's ready for the physician at the time of discharge. One piece of feedback I actually got this week that was kind of an aha to me in these early few months in doing this transition was, when your team is filling that out, there is a retail pharmacy option at Tipton. It's not to serve the inpatients, it's actually for team members only. It was one of those like, oh gosh, I didn't even think my team would be selecting that retail pharmacy, but they are. So that has caused some kind of back end frustrations with some of the physicians because they know they're not supposed to be sending scripts there. So then it's just extra work they have to do to go through, change that, or call pharmacy to have them help with that. So little nuances like that we didn't really think of at Go Live that have come up, which have been really great learning opportunities and just coaching my team through how we can change our process and all of that to better serve those patients.
Having open communication and a team that's resilient, adapting to change and willing to do that is important in a new process. So good to hear it's going well. Lessons learned that you're willing to share with those who are looking at a virtual medication history process or struggling to complete the medication histories in their current structure. What would you share with them? Ideas, thoughts, as you've worked through this in various hospitals over a number of years now?
If there's institutions that are looking to shift work or start a program from the ground up, I'd say if there's any way you can show the value of what the current team is in this whole admission process, that's helpful. So we are very lucky with IU Health. We have many different reports and BI dashboards that I can pull and look at my team's productivity and to see when are my busy times. Like my busy times are actually in the evening. That's one kind of thing I've learned over the years is, while it may not be something that every team member wants to do, like our evenings are our busiest time. We had, no night shift coverage in the past week, and we came into 31 med history. So it tells me like our night shift is where we need to have assistance. So I think just looking at the data and just working with that data to see where can I shift? Can you be creative with any of your current FTEs to support day shift or night shift a little bit better to kind of get some of that work done? My biggest lesson learned through all of this is showing the value of this work to leaders to help get more FTEs if that's, a possibility. I would not be able to do what I do with my team and get the results that we have if we didn't have people to do it. My goal for the team is if we can try to get medication histories done in 30 minutes, that's ideal. But we all know some of them take an hour. So to spend an hour with one patient just doing the documentation and the interview is like a really long time. So sometimes it does take more than 2 FTEs to really dig out of that hole of the number of patients that need to be seen in a 200, 300 bed hospital. There does need to be dedicated FTEs to the process for sure to make it successful.
The important part, having the stories to share so they understand the importance of setting the table on admission and how that improves the discharge process. As you stated, getting the medications correct, knowing where the patient wants the prescription sent, so there's no gap in care at discharge, no medications not prescribed or picked up or followed up. And so it does improve. It's the first step to improving the discharge transition to care and the vital component of that. Sharing those stories is critical. Jenny, thank you for sharing how IU Health Arnett and its partner hospitals have built a sustainable, high-performing medication history program. Your team's work not only improves transitions of care, but also sets a model for other health systems facing similar challenges. That's all the time we have for this edition of Knowledge on the Go. Thank you for joining us. Please join us for more Knowledge on the Go. Subscribe today, like us, and send us your comments at picollaboratives@visientinc.com. For Visient's PI program team, I'm Jim Lichauer.